Welcome everyone to our YouTube channel for the urology exam preparation. Today we have a trainee volunteered to discuss various scenarios on pediatric urology. Thank you for allowing us to record so that it's a good source for the other trainees. Anish, floor is yours.
Thank you so much, and good morning, everyone. Today we will discuss a couple of very uncommon scenarios, and most of the time, when these scenarios are seen in the exam, it's a bit difficult for us to go through the whole discussion. Not because of our knowledge, but because we are not used to have a practical exposure or a day-to-day practice exposure to these scenarios. So we'll go in depth into these scenarios and uh, our main aim is to see how to approach the exam with these scenarios and also mainly to stick on to the principles of management. So without further ado, we'll start the session. So you are in the pediatric urology clinic. You've been referred a child with the following finding. I'll share the screen now. So this is a finding of the child. What are your thoughts? And can you tell me what is going on there?
So this child has a ulcerative lesion at the back, and my suspicion is a spinal bifida myelomeningocele in this patient.
All right. So how are you going to approach the child? What all things are important in the history?
So approach to this child will be a multidisciplinary team approach, including the urologist, pediatrician, neurosurgeon, orthopedic, physiotherapist. All these need to be involved. My approach, I will ask about the prenatal history first, any problem with, if the mother is aware about any problem during pregnancy. I will ask also about the delivery of the child, whether normal or cesarean, any immediate difficulty after birth. Can I ask, please, how old is the child?
3 months.
3 months. Okay. I will ask about his well-being, about his feeding, whether he's opening his bowel, whether he is passing urine or not. Any urinary tract infection happening during this period. I'll ask also about the order of the child in the family, any similar problem in the sibling or any positive family history. And I will ask about if there's any intervention done, because usually the neurosurgeon will be involved very early by closure of the defect. What about the movement of the lower limbs and the other things? And then on examination in the presence of chaperone and the mom, I will check his weight and length against the growth chart. I will examine the abdomen looking for any palpable mass. I'll examine the genitalia looking for any associated abnormality like hypospadias or undescended testis. And I will examine the rectum as the anus, because there is a high risk of associated anorectal anomalies. I will examine the back and examine the lower limb neurological examination and take it from there.
Okay, that's well done. You have comprehensively covered all the necessary approaches to a patient or to a child with this type of presentation. What are your main concerns in this child apart from the external appearance?
My main concern, urological wise, is a neuropathic bladder in this patient. So, and this patient, I want to know whether he is in retention or he is passing urine. And then if he is passing urine, I want to know about the upper urinary tract, whether there is any dilatation or not, about his kidney function, and whether there is any infection or not.
Well done. So, what is the developmental anomaly background of myelodysplasia? What's happening there?
In myelodysplasia, the main risk factor is folate deficiency during pregnancy. due to lack of folate supplement not taken by the mother. So this will affect the development of the neural tube, and there is incomplete closure of the neural tube, which cause this lesion, which is usually associated with a neuropathic bladder.
Okay, well done. And with the intervention by the governments of supplementing the folic acid, has it improved the condition?
Yes. Yeah, significantly improved following a regular supplementation of folic acid to all ladies within the pregnancy, within the childbearing age. Even they need to start the folic acid before they become pregnant.
Okay. And does all neonates have neurourological dysfunction at birth when they have meningomyelocele?
Most of them they have. And we have another latent form of spina bifida, which is called spina bifida occulta, which may appear later on. Usually when the child, there is a growth spurt around the puberty, so it may present late sometimes, and externally there is no ulcerative or obvious defect.
Okay, well done. And regarding a comprehensive approach, what are the main goals of treatment when you see a child with myelodysplasia?
The main goal of treatment is to protect the upper tract from the high pressure, and then after that to prevent the infection, and then to try to keep the child dry and independent. So these are the main treatment goals from urological point of view.
All right. For that answer, I would suggest a bit more improvement in the sense that for pediatric urologists or even pediatricians, it's a long journey, isn't it, until the level of puberty. So you said you started really right just by saying that you will protect the upper tracts, prevent any UTIs, will continuously monitor to see for any progressive urinary tract deterioration. We have to make a goal so that the child will achieve continence at an appropriate age, and we had to always maintain the good quality of life. Parent education is important, and as well we have to make sure that the bowel is functioning normally, and as the child grows, we have to address the sexual function when the child reaches puberty, and almost there's a high risk of these children developing latex allergy. So whenever there is any procedures being done, we have to make sure that the environment is latex free.
Yes.
So our child, there is not much of neurological deficit seen. I mean, it's only 3 months down of life. So the neurosurgeon, he was reviewed by the neurosurgeons and the orthopedic team. There are no orthopedic abnormalities. The neurosurgeons managed to close the defect primarily. You are seeing the child at 6 months of age. There is no investigation. I mean, the kidney function tests are normal. What other investigations will you do to make sure there's nothing abnormal going on?
Yeah, I want to have an ultrasound to check the bladder, whether there's any thickening of the bladder or diverticuli, and I want to check the upper tract as well by ultrasound if there is any hydronephrosis.
Well done. What is the ideal time to do an ultrasound scan in a child with myelodysplasia?
It depends. If there is antenatal hydronephrosis, then I will do the ultrasound early, usually after 1 week of age. Okay. But if there is no prenatal hydronephrosis, I will do the ultrasound at initial assessment at 3 months.
Okay. And what are there any other investigations that you have to do?
I need to do a urine dipstick to make sure that there is no infection. I will check the kidney function test, and I will do the ultrasound initially. If the ultrasound is showing any hydronephrosis, then I will think about doing other investigation.
What about urodynamics?
Yeah, Urodynamic study, it will give us an idea about the baseline status of the bladder. So I will do the urodynamic study at the age of 6 months. I will cover the patient with antibiotic as well to avoid any infection.
Okay. It can vary, the practice can vary, but for the exam purpose, the EAU guidelines suggest to do the initial urodynamic study at 3 months' time. Uh, it varies in the AUA. It says that it can be done between 2 to 4 months' time. So, but the main emphasis is we cannot do it at birth, but maybe a baseline urodynamic study at 3 months of age is a good one for a person that we are suspecting a neurogenic bladder.
Yeah.
What are the parameters that you look for in the urodynamic study?
So on the urodynamic study, I'm looking for the compliance for any detrusor overactivity during filling, bladder capacity and sensation.
Mm-hmm.
And then I'm looking in the voiding for any feature of obstructive voiding.
Okay. Are there anything specific that you look for, especially in children with neurogenic bladder?
I'm mainly looking for the intravesical pressure to see whether he's at risk of upper tract damage or not. So if there is an intravesical pressure of more than 40 to 50 centimeter water, this is a risk factor for development of upper tract damage.
Well done. This answer can be used in any urodynamic question, because the urodynamic questions can come in the overactive bladder as well. So when the question is asked what all parameters that you look for in the urodynamic study, we can divide it into filling phase and the voiding phase. And in the filling phase, we look into the cystometric capacity, the intravesical filling pressure, the detrusor compliance, and in the voiding phase, we will see the intravesical pressure. In children, it's very difficult to see voiding, but sometimes we can say that the intravesical pressure at voiding or leakage, any presence of any overactive detrusor, and mainly if there is any detrusor external sphincter dyssynergia.
Yeah.
And the answer is complete by saying that I'll also measure the post-void residual. Any urine volume is there.
Okay.
What's the role of MCUG?
Usually I think the role of MCG may be limited because in these children, we expect to see some degree of hydronephrosis, either unilateral or bilateral, due to the high intravesical pressure.
Mm-hmm.
I would say maybe we'll do the MCG if we suspect an associated anomaly with the neuropathic bladder, or maybe for assessment of a bladder diverticulum as well.
Yeah, so ideally, even though we say that it should be urodynamics, for these children, if possible and if available, video urodynamic study is the gold standard. If a video urodynamic study is not available, then a standard urodynamics compounded or supplemented with a VCUG is an accepted option. Especially the role of VCUG is to roll out a VUR, associated VUR.
Yeah, because we expect most of these children, they will have a secondary VUR due to the high pressure.
Well done. Yeah, and in that case, if there is a secondary VUR, it is very important to start them on prophylactic antibiotics.
Yeah.
And there is also role for DMSA. If you suspect, like in the ultrasound scan, if there is any thinning of the parenchyma, then it is important to have a baseline DMSA and then if needed to follow it up later.
Yeah.
So when the question comes, usually when the discussion progresses, it's history, physical examination, and then the baseline investigations. And then when it's asked for any specialized investigation, especially in a neurogenic bladder, even in adult neurogenic bladder, we can say that we will bring in the options of urodynamic study, VCUG, and DMSA, depending on the clinical scenario.
Yeah.
So coming to the management, you rightly said that the primary management is to make sure that there is no deterioration of the upper tract as we move on. What are the measures by which you make sure that the upper tract will not get deteriorated over time?
So usually for these children, we will do a serial ultrasound to start with every 6 months, and then annually to check for the hydronephrosis, serial checking of kidney function,
Sorry.
and urine. And also, these children, they need to have a urodynamic study regularly because the behavior of the bladder may change over time. So they will need to have a urodynamic study. Usually, if we start at the age of 3 months, then we need maybe to do it at 1 year, and then it need to be done at the age of 5 years, and then taken from there.
Okay. What are the treatment options that you provide if the urodynamic study shows non-compliant bladder?
So to start with, we can start the child on anticholinergic medication. If there is incomplete emptying, then we can teach the family to start self-intermittent catheterization.
Okay, so yeah, so early management of intermittent catheterization is very much advisable. What is your anti-muscarinic of choice for children?
Oxybutynin is approved in children, and the dose is 0.2 milligram per kg.
Yeah, so 0.2 milligram per kg 3 times daily. And what are the other options?
The other option, if the child is not responding, then we can consider intravesical Botox injection. If there is still no response, then, and especially in the presence of poor compliance, small capacity bladder with high intravesical pressure, then the option is to go for augmentation cystoplasty.
All right. What are the advantages of antimuscarinics?
The main advantage is to reduce the pressure inside the bladder and increase the functional capacity.
And what about Botox? What's the difference? What extra advantage botulinum toxin has got?
Botulinum toxin usually is more effective than the anticholinergic medication, because the anticholinergic medication, the success rate usually is around 50%, while in the with the Botox, the success rate can be 70 to 80%, and it gives a good response usually for about around 9 months on average.
Okay, so it decreases the detrusor pressure, and it increases the cystometric capacity, and the studies has shown that it can improve the bladder compliance as well.
Okay.
And what about beta-3 agonist in children?
I'm not aware about the use of mirabegron in children.
Exactly. So there are no good studies to prove the effect of beta-3 agonist in children. So there is it's not recommended. What about are there any role for alpha blockers?
Yes, sometime if there is a hypertrophied bladder neck, and in the video urodynamic, it showed feature suggestive of bladder outflow obstruction, then some of the pediatric surgeon, they prescribe alpha blocker.
Yeah, exactly. So that is also recommended too, because if there is a residual urine to facilitate better bladder emptying, alpha blockers can be prescribed. Coming to the onabotulinum toxin A, what is the dose of Botox in children?
I'm not aware about the dose, but
so it is 10 units per kilogram.
10 units per kg.
Yeah, 10 units per kg body weight. And there are enough studies, even ranging up to 10 years follow-up, saying that the Botox is effective up to 10 years in one of the study.
Very good.
And you said, is there any role for vesicostomy in children?
So usually vesicostomy is a rescue procedure if self-intermittent catheterization failed, and then permanent uterine catheterization or suprapubic catheter is failed to control the infection and the high pressure inside the bladder, then a vesicostomy is considered, and usually it should be a temporary measure, so it should be closed after a period of time.
Okay. And you mentioned about augmentation cystoplasty. which bowel segment will you use for augmentation cystoplasty?
I will use the terminal ileum. So usually we take a patch about 15 to 20 centimeter, which is taken about 20 centimeter away from the ileocecal valve. And then this segment of bowel will be opened, detubularized, and then the bladder will be bivalved as low as possible, very close to the both ureteric orifice, so the bladder will be bivalved transversely, and then this patch of bowel will be sutured on the top of that. The aim is to increase the capacity and decrease the pressure inside the bladder by adding an contractile segment to the bladder instead of the detrusor muscle.
Okay, well done. Only if you are in a pediatric table, I would suggest to avoid the measurements like 20 centimeter because the measurements are a bit different for pediatrics.
Yeah.
So I would suggest to stick on to the principles only because the 20 centimeter, I think it's mainly for the adult bowel measurement.
Yeah.
What are the complications of augmentation cystoplasty?
Augmentation cystoplasty has a lot of complication, early and late. Early complication, like any other surgery, bleeding, infection, pain, anesthetic complication. Complication related to the bowel, like intestinal obstruction, bowel leak, ileus. Late complication is a local and metabolic complication. So local complication like excessive mucus production, recurrent UTI, need for self-intermittent catheterization for drainage of the bladder, and on the long-term low possibility of development of cancer, and also very low possibility of spontaneous rupture of the augmented bladder. Metabolic complication include hyperchloremic metabolic acidosis, osteoporosis on the long term, and vitamin B12 and folate deficiency, malabsorption of the fatty vitamins. Also, one of the local complications is development of stones in the augmented bladder as well.
Okay, well done. And regarding the risk of malignancy, what is the incidence of malignancy in augmentation cystoplasty?
Usually, the incidence of malignancy in augmentation cystoplasty is very low, around 1 to 3%. But certain people, they may have a higher risk, like in posterior urethral valve, children who are having urethroplasty, who's having augmentation cystoplasty, they may have a risk up to around 10 to 15%.
Okay, and also, if usually it is not done nowadays because of the hematuria, dysuria syndrome, but if you use gastric segments for augmentation cystoplasty, that also carries high risk of malignancy. So during the follow-up, you nicely mentioned about the blood, the blood status follow-up and other things. How do you follow up regarding the risk of malignancy?
So, although there is a risk of malignancy, but there is no clear guideline or protocol say that to follow the child with a regular endoscopy, but usually the risk will start to increase after 10 years from the augmentation cystoplasty. So in this patient, I will keep a close eye if the child developed any symptoms like visible hematuria. Then I will keep a threshold to do a cystoscopy for them.
Okay, yeah. So you're right to say that there is the data on the follow-up of that one is really poor, but the recommendation is to start the annual cystoscopy after 10 to 15 years of augmentation cystoplasty, especially if there are any red flags like more than 4 UTIs per year, or if there is gross hematuria, or if when you do the ultrasound scan for follow-up, if there is anything abnormal in the bladder, these should trigger the annual cystoscopy follow-up.
Yes.
Well done. How do you feel about that discussion?
Yeah, no, it's nice. I am the neuropathic bladder and spinal bifida. Maybe we don't see here much here, but back home I've seen a lot of these unfortunate children.
Okay. I mean, you have a really good approach and systematic way of approach to. I mean, that's a key, isn't it? If you are not seeing it in the day-to-day practice here, then it is the systematic approach to the case that will give us. I mean, definitely that will take us over the mark. One of the senior consultants who came for FRCS Viva session, the advice given to me was, I mean, to us was that even if there is a urodynamic study which is very, which is not clear, or if you feel that it is a very complex one, his advice was to just go on with the description, uh, to so describe everything systematically, which you did really well in this one. Thank you.
Thank you.
Shall we move to the next scenario?
Yes, please.
So you are again in the pediatric urology clinic. You receive a letter from the GP for a 4-year-old boy with concern of hypospadias. How are you going to approach this one?
So I will see the child in my dedicated pediatric clinic. I will take a focus history, mainly concentrating about the prenatal history, about the delivery of the child, about his growth and vaccination, overall well-being. I will ask about his order in the family, any similar condition in the sibling or in the parent, any positive family history. I will ask about any difficulty in passing urine, any spraying or soiling of his clothes, any previous intervention done for this, especially if there is any circumcision done or not, any associated difficulty like difficulty in passing urine or previous infection. I will ask about the drug history. And then in the presence of a chaperone with the mom, I will examine the child, general examination, and then I will examine the abdomen looking for any palpable masses. I'll examine the foreskin. I will expect for this child to have a hooded foreskin. I will examine the hypospadias to see the degree of hypospadias, whether it is a glandular, coronal, distal penile, mid-shaft penile, or proximal penile or penoscrotal. Hypospadias regarded by some pediatric surgeon as a degree of it's may associated with low androgen level and possibly disorder of sexual development, especially when it is a penoscrotal or proximal penile. So I will make sure that both tests are palpable within the scrotum, and also I will check the anals for any associated anorectal anomalies, and I will examine the back and do neurological examination as well.
Okay, so I will share the slide now. Can you see that?
I can see it, but a little bit hazy. I don't know.
Sorry for the picture.
But I think there is a coronal hypospadias with a hooded foreskin.
Hooded foreskin. Okay, and what's the third most important component that you look for?
So it's usually hypospadias is composed of 3 components, which is the ventral meatus, the hooded foreskin, and the chordae.
Chordae. Okay. What is the association of cryptorchidism with hypospadias?
About 10% of children with hypospadias, they may have a cryptorchidism. And if the cryptorchidism is bilateral with hypospadias, then this child should be assessed for disorder of sexual development.
All right. And how are you going to approach a child with a mid-shaft hypospadias with hooded prepuce?
So for this child, my main concern is that it will affect him psychologically when he passes urine, because he is going to drop urine on his clothes, which will cause him a problem, especially around the school age. And in the future, it may interfere with the ejaculation of sperm into the female genital tract. So usually if it is a mid-shaft penile hypospadias, then this child need to have a repair. I will advise the family not to consider a circumcision in any child with hypospadias until the repair is done. Sometimes there may be associated hypoplasia of the urethra with the hypospadias. So for this child, sorry, what's the age of the child?
Yeah, he's presenting at 4 years of age.
Yeah. So at 4 years of age, I think he is. We can do the repair of the hypospadias. And I would recommend to do a cystoscopy first to make sure that the remaining of the urethra is normal, no associated anomalies in the bladder. And then after that, we will do closure of the hypospadias, preferably in one stage. If not, then sometimes some of the children, they may need a second stage.
Okay. In this child, during the process, so you counsel them for a hypospadias repair. There is a possibility that we might get away with a one-stage repair. So you put the patient is under sleep, consented and everything done. You put a ureteric catheter and you confirm that the distal tip is exactly at the mid shaft. What is the preferred surgical approach for this child for a mid shaft hypospadias?
Yeah, I am aware of many types of hypospadias repair. There is about 250 type of repair.
Right.
But for this child, we can use the tubularized incised plate or the tip procedure. Yeah, so we...
What's the difference between the TH duplet technique and the TIP procedure?
So what's the first one?
So the most commonly used techniques are one is the TH duplet technique, and the other one is the mostly known as the tip technique, which is the tubularized incised plate, popularized by Snodgrass. So it is popularly known as the Snodgrass repair as well. So the main difference that we can say is once you assess. So as you correctly said, there are three main things that we have to look for when there is hypospadias. One is regarding the position of the meatus, one is the hooded prepuce, and the curvature. So during the procedure we have to do an artificial erection, either using saline or the medications, and see what's the curvature is. If the curvature is more than 30 degree, then that might need, depending on the position of the curvature, mostly it is a ventral curvature, so it might need a dorsal plication, or if it is really bad curvature and very deformed penis, then we might even have to do a ventral incision technique.
Okay.
And the other thing that we have to look for is the urethral plate. If the urethral plate is wide enough, then we can straight away go for a tubularized technique, and that is the TH duplet technique.
Yeah.
But if the urethral plate is narrow, then it has to be incised. So that's why it is called tubularized incised plate.
Yes.
We will incise the on the dorsal aspect and then tubularize it over a catheter.
Yeah.
Sometimes if the urethral plate is very thin or if it is very ill-formed, then even we might have to use a inlay graft.
Yes.
And yes, as you said, there's lots of procedures described for hypospadias, even to the extreme that there is only techniques also described. But for the exam purpose, we can put it like if it is like a distal, like a distal hypospadias, or if it's only a very near to the external meatus, even we can use a magpie technique.
Yeah, magpie or Matthew,
yeah, or even Matthew technique can be used. And for a mid shaft, depending on the urethral plate, we can use the TH duplet technique or the Snodgrass repair. And also there comes the fact of the curvature of the penis as well. Depending on if it is less than 30 degree, we don't have to go for the corrective techniques, but if there is a severe CODI, then either a dorsal plication or a ventral incision and grafting.
Yes.
So it's just going through. I don't think there will be any deep discussions on that one. But if we know that there is a possibility that we might get hypospadias during the discussions, and if it is very proximal, then we can say that we can go for the two-stage technique, where we can initially use a graft to cover the defect and then tubularize it later.
Yeah.
Okay, I think we will stop there. Mr. Dhanasekaran, are you?
So, are we going to discuss more scenarios or?
It's sorry, I have to leave a bit early. That's the reason.
Yeah. No worries.
That's a good discussion. My another take-home message for you guys exam preparing is sometimes in the exams, hypospadias will be just a single scenario for the full 10 minutes. How to differentiate or how to know that the examiner is going to ask only hypospadias for 10 minutes, or he's just going to finish off and give us another scenario like the one which we discussed, like spina bifida or undescended testes, because there is a good possibility sometimes in pediatric urology you will be having multiple scenarios in this 10 minutes itself, like the technology table, etc.
Yeah.
So how to differentiate is see the pace of the examiner. If the examiner is asking questions very quickly, leading to investigations, treatment complications, that means the examiner may have some more scenarios in mind to ask. It's a very good option for the trainees, because if you discuss multiple scenarios, your scoring will be better, and at least 2 out of 3 or 3 out of 4 scenarios, you will really do very well. So just to see the examiner's pace, and if the examiner is very quick in asking, it means he is expecting multiple scenarios. So don't give a very prolonged, slow answers and try to drag the time. Sometimes, very rarely, even the spina bifida maybe one scenario for the full 10 minutes. In that case, you need to discuss quite in detail. You need to discuss about why you are sparing the 40 centimeters of the distal ileum, vitamin B12 absorption. So discuss everything in detail so that you get the best mark out of that particular table.
Yeah.
Okay. So that differentiation is important, especially in technology and the pediatric urology. Whether it's a multiple, you can even openly ask the examiner, nothing wrong in it, but with experience, we can easily judge the pace of the examiner. Very good. Again, a very interesting discussion. Both the scenarios are very important. We will have some more sessions in pediatric urology since we have a lot of grounds to cover. And have a good rest of the day.
Yeah, thank you very much.
Thank you so much. Have a nice day.
For you as well. Thank you.
Bye.
Bye.
So I'll stop the recording now. I'll trim it from here.
Yeah. Now you actually Ibrahim has left, Danish.
Okay.
So when we say that bye, thank you, at the time you can stop so that you don't have to even trim in the end, isn't the edges.